All right. Today I'm going to be talking about osteopathic medicine. It's going to be a very basic, rudimentary, introduction to it. The audience is all MD, so the goal is not necessarily to have you proficient in osteopathic medicine, but to be comfortable with it being utilized as you, the supervisor. Okay. So feel free to ask questions when they should arise. The goals are to describe the 4 tenets of osteopathic medicine, recognize the ways in which you already teach osteopathic medicine. By the end of this, you should all be able to do the evaluation section for the osteopathic part, attain adequate comfort level with OMT, to supervise DOs while they're performing OMT. And understand the basic mechanics behind the various modalities that we're going to be talking about today, and identify scenarios in which OMT may not be the best treatment option, and also when it would be a good treatment option. Just a little bit of background as to osteopathic medicine in general. It was officially started on June 22nd, 1874. They make a big deal about this date, and it's often tested in one of the introduction classes, so I thought I'd put it in here, by A.T. Still. The intent was not to make a distinct profession or a distinct entity. It was to enhance upon or build upon what was already out there, and at the time, and currently still is, allopathic medicine. The first osteopathic school was started in Kirksville, Missouri. It still stands today. The AMA first recognized osteopathic as full members in the late 1960s. Doctor of Osteopathy or Doctor of Osteopathic Medicine is one of the 2 medical degrees that is recognized and awarded in the United States. And as of 2018, there's 35 schools, so we have a lot of students that are graduating with osteopathic medicine degrees. 55 total campuses, so many of these schools have satellite campuses. I graduated from LECOM, Lake Erie College of Osteopathic Medicine, and it had 3 total campuses. With all of these campuses, 1 in 4 graduates will be an osteopath. So one of the big things we're finding now that the ACGME is merged, and even before that, was how do we effectively teach OMT? OMT is like the defining difference between osteopathic and allopathic practitioners or physicians, in that the osteopathic medical students are taught this intensively for the first 2 years, and occasionally throughout their 3rd and 4th years, depending on their preceptor and their clinical sites. The issue is that most DOs don't practice. We have a lot of DOs on staff here at the hospital, and not a single one practices actively. Do they know how to do some manipulations? Yes, but do they practice in a clinical setting? No. And also the majority of our faculty and faculty across academic institutions are MD. The other issue, as I've mentioned before, is that the first 2 years is where the intensive osteopathic education happens. The 3rd and 4th year is where that tends to kind of fade away, because it's all very much dependent on what site you're at and the preceptor that you have. So this is an important slide. These are the tenets of osteopathy. This is basically the philosophy behind the field. And if you look at it, it doesn't really look that much different than how we all practice anyways. We all understand that the body is a unit, and that most often that the body systems are interrelated. Osteopathic medicine just defines it as the core principle of overall health, that the body is a unit, mind, body, and spirit. If any one of those things is compromised, we do not have health. We do not have good health. Form and function are interrelated. That just means that basically the body is designed to perform a specific function. And if the form is disturbed, then the function has to be disturbed by default. And we also recognize that the body has the innate ability to heal itself. So one of the thing to understand about this is that we must understand and accept that we ourselves are not healing the body. We are attempting to create situations in which the body can heal itself. So creating the environment for healing allows the body to repair itself. We have no direct control over how the body heals. The best surgeon could perform the cleanest surgery, but if the body refuses to heal, it doesn't matter. And also, the last thing is that osteopathic manipulative treatment is based upon individualized and rational application of the above tenets. So each person is unique, and not all treatments are going to work for everyone. Everyone's specific state of being needs to be taken into account when you are selecting which modality to use or how to treat them. So there's two key questions that you can do to prompt for OMT. So if you recognize a situation where OMT would probably be indicated, then you want to actually just directly ask them, what did you find in your structural exam? All osteopathic residents should be able to do a very thorough structural exam. The structural exam basically looks at the entire body looking for dysfunction. Dysfunction is categorized in 4 different ways, which we'll go over in a little bit, but they're summarized as TART changes: tenderness, tissue asymmetry, restriction in motion, and tissue texture changes. And even if OMT is not feasible at that time, it still can be discussed as like, this is we can have them schedule for a follow-up, or we can advise them about doing or getting osteopathic manipulation in the future. So what is the structural exam? It's essentially looking at the body, and for the most part, when someone is watching someone do a structural exam, they're identifying asymmetry for the most part. So all the symmetrical body parts are basically palpated and checked to see if there is asymmetry. If asymmetry exists, then somatic dysfunction also must exist somewhere. Some of the key landmarks, as noted up here, are the inferior shoulder blades, the iliac crest, the PSIS, the ASIS, the shoulders. These are just some of the things that a resident would be looking for if they were doing a structural exam in front of you. I don't expect that you all would do structural exams, but if you should be able to at least understand what are they looking for. And as we mentioned before, they're looking for the TART changes. Just because it's symmetrical doesn't necessarily mean that there's no dysfunction there. If they have tenderness there, that's a dysfunction. If their range of motion is restricted in that particular joint, there's a dysfunction there. If there's tissue texture changes, so basically if you can feel a spasm, or they don't feel quite the same, one feels a little bit tighter or a knot, that's a somatic dysfunction. Any of these things, we call them somatic dysfunctions. Okay, so how does OMM really play into this? In the types of dysfunctions that involve barriers, restrictive barriers, like the key thing that we're addressing. A lot of the manipulations deal with the restrictive barrier. So just to remind you all, the physiological barrier is the normal function. The anatomical is where the joint can comfortably go, but usually with passive assist. The restrictive barrier is somewhere before the physiologic barrier. The physiologic barrier is where ideally everyone should be able to go when they're actively doing an active range of motion. So when you find a restrictive barrier, that's when OMM would be indicated. There's two fundamental types of techniques. One is called direct and one is indirect. The direct techniques are the ones that are engaging towards the barrier, so you're going to the restriction. The other is indirect, where you're moving away from the barrier, which is going towards the ease of motion. So this is kind of where the modalities differ. Some of them that we would consider to be a little bit more aggressive are going towards the restrictive barrier, and some of them that are not as aggressive are going away from the restrictive barrier are indirect. This is where kind of your clinical judgment comes into play. Is if someone has an acute problem, an acute illness, an acute pain, unlikely that they're going to tolerate a direct technique. So if they say it hurts when I move my head to the right, and the resident is moving their head towards the right, and you can visually see the patient wincing, that's probably where you should say, why don't you try the other way? Why don't you try an indirect technique? So that's kind of like what the difference is between direct and indirect. There's many different kinds of techniques and maneuvers, and we're not going to be discussing all of them. We're just going to go over the ones that I would say, without a robust training or education in them, that you should feel fairly comfortable watching being done. And some of these words don't make sense yet, but we'll get to them. So one of the most common, this is the one that like every resident should know how to do, and this is something that you all should also be familiar with, is the OA release. The OA is the occipital atlantal joint, and it's basically where those two green areas are. When someone comes in with a tension headache, more than likely they have dysfunction in the suboccipital area. In osteopathic medicine, we would call that a cranial manipulation because it is above the cervicals. So the treatment for this is essentially having the patient lay down onto the fingers. So it's a supine position. Lay down on the fingers and have their head rest onto your fingertips. And the weight of the head itself, after 30 seconds or so, should help relax that the junction there, the trigger points there, and the muscles should relax and there should be relief. So much so that there's actually many different devices out there that you can buy for tension headaches which capitalize on those 2 points. So if you see these little like post-looking things that you're just supposed to lay your head on, that's what they're doing. They're doing a suboccipital release. I usually have patients, if they have 2 tennis balls at home, I tell them to tape them together or put them in a sock and then lay on them, and that also achieves the same effect. So everyone should be able to do this, whether they have training or not. And this is the one that when you ask them to do, show me just one OMM technique, this is what everyone will go ahead and do because it requires no practice in order to do effectively. And it's very, very safe. And little babies are often done after they've been born. Newborn nurseries tend to do this that have osteopathic physicians or residents coming through it, and it's supposed to help them decompress the neck for better suckling and better latch, with the idea that during birth or while they were in utero that their head may have been held at an angle that caused a little spasm, and that's why they're not suckling, because there's some compression on some of the cranial nerves. So this decompression is done pretty routinely by osteopathic physicians who go to the nursery.
So basically a baby's crick in the neck?
Yes. Yeah, and it's a very, very gentle technique. It really requires almost no effort because you're not actually doing anything, you're just holding a position, and the weight of the head should do the release. Okay, so this is one of the simplest techniques that you can do. Also, when we're talking about the autonomic system, the OA is considered to be something that helps normalize the parasympathetic autonomic system. The next very commonly used manipulation is rib raising. If they don't do OA, they'll do rib raising. Rib raising is basically engaging the posterior angles of the rib and applying some anterior pressure to it and holding the muscles. Now we're going to go through all of this when we do our demo section, so I'm just kind of briefly explaining it. The idea behind here is it's supposed to restore normal rib cage motion and also normalizing the autonomic system. How does it normalize the autonomic system? The sympathetic chain tends to be just around that area where you're engaging the ribs. So that's the theoretical objective behind doing rib raising. It's also one of the very gentle techniques. So patients who are hospitalized, rib raising is often done for them to help normalize irregular heart rates or irregular respiratory rates, irregular GI function by engaging the sympathetic chain. So both of these techniques, the OA and the rib raising, would be considered to be soft tissue or myofascial techniques. Essentially, you're engaging the myofascia. The important thing about soft tissue techniques is that when you're performing them, it's important that you actually engage the myofascia. A lot of people tend to have excess adipose tissue, so you're not really engaging the myofascia, you're engaging the adipose. So it's important to really identify when you're feeling muscle and fascia below rather than just adipose. Myofascial techniques can be direct or indirect, as we mentioned before, into the barrier or out of the barrier. And it is in multiple different planes. So for large surface area places like the back, for example, the thoracics, I usually have the residents engage 3 different barriers. So what does the 3 barriers mean, or three planes of motion? Anterior, superior, cephalad, caudad, right, left, clockwise, counterclockwise. Now, when you engage the barriers, you first have to decide, okay, what am I doing? Am I doing it at direct or am I doing indirect? And as we mentioned before, if there's a direct there's acute injury, direct is often uncomfortable. So indirect would be fine. More often than not, patients don't come right away when they're in an acute, so a direct technique should be okay. In the direct technique or indirect technique, what you would do is you would move in one plane. Let's say we're doing the caudad, cephalad caudad, and see where you feel the barrier. If it's a direct technique, you kind of find where there's less motion. So if I'm coming up and down, if I go superior and it's less motion than if I'm coming inferiorly, then I'm going to go to the superior because I'm doing a direct technique. You're going to hold it there. That's the important part when you're doing a multi-plane soft tissue manipulation. Hold it there and then move to the second plane, left or right. Find the restriction, hold it there, then add your clockwise, counterclockwise. So essentially it would be this kind of motion, okay? So you end up in one quadrant or another because you've moved in 3 different planes. That's, again, if there is a a large surface area like the back that this would, or lumbar that this would work in. The goal is to relax the hypertonic muscles and reduce spasm, and to stretch fascial structures that have been shortened due to the spasms. The benefit is enhancing lymphatic circulation, improve local tissue nutrition, oxygenation, and removal of metabolic waste. Now, notice I call it theoretical benefits because there's not really a way to prove that. Contraindications, there's very, very few, but if there is a skin infection, which like an abscess or an open area, you probably don't want to manipulate the skin because it's still trying to repair itself, so the integrity of the skin would become compromised. That does not mean that if you have a scratch or a little pimple that you can't do this technique. It's if you have a hole where it shouldn't be there, or something that was substantial, an incision. It would be what normal clinical judgment would take over and be like, okay, there's an incision, there's stitches, but probably shouldn't do anything that's going to manipulate that area too much. Acute fasciitis, they're probably in the ER, so it shouldn't be an issue. Muscular neoplasm, so if there is known malignancy, there, then don't manipulate that area. Lipomas are fine as long as we know they're lipomas. Cysts are fine as long as we know they're cysts. But if there is a tumor or sarcoma or something like that, then that is a contraindication. Acute ligamentous strain or myositis. Ligamentous strains, if this person has a structural defect, then don't manipulate it. I don't think that it's wise for a resident to manipulate a damaged area without proper supervision from someone who is skilled at manipulating a structurally compromised area. Osteoporosis, so this is a relative contraindication, okay? If she's 85 years old and very frail, this is probably not a good technique because it requires you to apply some type of force to engage the myofascial structures. But if they are barely have osteoporosis and you're confident that they're not on the verge of a compression fracture or they're not very brittle, then this technique is okay. As I mentioned, the steps, you palpate for the restriction, you apply your compression or traction to engage the area, twisting and transverse forces, and then once you have it, you wait until you feel the tissues kind of relax a little bit under your hand, and that's when the technique is completed.
Good.
Cutscene.
Sorry.
All right.
Tasty.
Okay, so now we'll move on to the next fairly common technique is strain counterstrain. So this is a passive technique, meaning that there is no involvement from the patient. The patient should not be assisting you in any way while you're performing this technique. This technique relies on the fact that you have complete relaxation of the muscle. If they try to help you, because a lot of times this is positioning, the entire technique is based off of positioning. If they help you, they've engaged the muscle that you're trying to work on, and you kind of have to start over. And it's an indirect technique. We're not taking it to any barrier. We're taking it actually away from the barrier. This is the point, the technique that you would use if there is a tender point. Like if a patient can say, it hurts right there, this is the technique that's going to be used. Sometimes they don't know it's going to hurt right there. If they're complaining of generalized neck pain, you can probably find a few separate points there that would be amenable to treatment with strain counterstrain. The steps is to locate the tender point. Once you've located it, So you've kind of palpated for it, you find it. You want to keep one finger on there as a monitoring. You don't want to continuously apply pressure, which is something that residents often forget. How I know they forget is because their fingernail is still white from applying pressure. It's extremely uncomfortable if someone has pressure applied to the tender point the entire time they're setting you up. So the goal is to just remember where that tender point is, because that's where you're going to be checking to see if your positioning is correct. So you want to position the patient to achieve optimal comfort at the tender point, which is the concept of fold and hold. Okay? So essentially you're going to be trying to shorten the muscle groups that are involved with that tender point. So you're going to probably flex around that tender point. If for some reason the flexion does not work, then go ahead and go into the direct opposite, which would be an extension. The most common time that you're going to have to flip from a flexion to an extension is if you're treating piriformis and lumbar, just this general area. That's the only time that that's the usual time that you would have to flip. But for the most part, if you're flexing the body around that point, you're okay. The goal for this is a 70% reduction in the discomfort. So you're going to, as you're adjusting the patient, you're going to be periodically checking the tender point to see if you have any improvement in the pain. There should be about 70% reduction for you to have found an acceptable point to manipulate. And then you're going to hold that point for 90 seconds, or if you feel that the tissue or the tissue has relaxed. And once you have the tissue relaxed, you need to return them back into neutral, again, passively. Until you are done with the technique and you're no longer touching them, the patient should not be involved. It's harder said than done. Most patients will try to help you bring their leg back or their neck back to neutral. So that's counter strain. Does that make sense? Does anyone have any questions? Okay. All right. The other very common technique is muscle energy. Muscle energy has two distinct ways that you can do it, or two types of muscle energy, I should say. For body parts that have multiple planes of motion, the idea behind muscle energy is that you would take that body part into all three planes. More likely than not, this is done as an active technique. Rarely is it done as an indirect technique. Or sorry, it's always done as a direct technique. It's rarely done as an indirect technique. So you are basically bringing the body part to all the restrictive barriers. So if the barrier is in flexion, you're going to bring it into flexion. If the barrier is rotation to the right, you're going to bring it into the right. You're just going to go to the point where you feel the barrier, rather than when they feel pain. If you feel pain, they need to just come back a little bit away from that point of pain. And then you have the patient return to neutral. So they're basically trying to straighten out their head, or straighten out their back, or straighten out their lumbars. That would be the post-isometric relaxation. So you take them all to the barrier. Once they engage, you tell them to relax after 3 to 5 seconds, and then you accentuate that restrictive barrier. So where you were before, it should have now, the barrier should have moved closer to the physiologic barrier, which is normal, okay? And you do this 3 to 5 times, or until you have returned to physiologic barrier. This technique can be taught to the patient to do on their own. For some things, like for a rotational restriction in the neck, the AA joint, where there's only really one plane of motion, which is rotation, they can do that to themselves. Tell them to take it until they feel it tighten up, and then bring their head back to normal, relax, and bring it further until they feel that restrictive barrier again, until they have back to a normal physiologic, or what their physiologic barrier is. Okay? Some patients, they have a functional limitation, and our goal is to optimize that functional limitation. For reciprocal inhibition, this is basically utilizing opposite paired muscle groups like biceps and triceps, things like that, where there is an antagonist muscle associated with the restriction. So if someone has a restriction in pronation or supination, you basically would have them pronate as much as they can and then reverse that and then take it to the next barrier. So it's not 3 different planes, it's just taking it to that singular plane and reversing it, engaging the other muscle. A lot of this, we're going to go over, we're going to do it with like a partner, so it's going to make a lot more sense. I just want to make sure that we cover the general areas, because if they say to you, I want to do muscle energy, it should kind of spark something. Okay. Contraindications. This is very much a case-by-case discussion. A thorough H&P, you can't replace that. That's essentially going to help you understand what is who has a contraindication and who doesn't. And you have to view the patient holistically, right? So if they have a pain somewhere, but they have metastases to the cervical thoracic spine, that patient is not a candidate for manipulation. Although the resident may say, well, they have back pain, maybe you should recommend them for OMT. Right? That's not a good patient. That's actually an absolute contraindication for referral to OMT. Now, is there anything we can do? Yes, but not in a way that would be meaningful for the patient, because we won't be able to engage the barriers. The thought behind that is, okay, if you have METs and you manipulate the area, we don't know what's going to break off and then travel downstream and then result in other METs. It's all theoretical, but that is something that I tend not to do. When there's an acute fracture, right, we're not going to manipulate an acute fracture. Compression fracture is the only one that we would potentially be able to do something with, but even then it should be a relatively stable compression fracture that is old and not new, and it's just a non-healing fracture. But then we have to make sure that they have been getting adequate treatment for osteoporosis, and another compression fracture or other fractures is not likely. Dislocation probably shouldn't be an OMT clinic if there's a dislocation. And they should have the dislocation taken care of. If there's something that has just recently been put back into place, then even then I would probably not manipulate that, just to avoid another dislocation. As once something dislocates, it's highly likely that it will dislocate again. An infection of the area that you're treating. If there's an infection or there's an acute illness that is resulting in fevers and whatnot, that patient is probably not a good candidate for manipulation at that point in time. And osteomyelitis, that's if it's directly over the site that you're working on. Relative contraindications, advanced age, okay? And that kind of comes back to osteoporosis, but certain people are just too frail to be moving around that much. Down syndrome, the reason Down syndrome is on this list is because of ligamentous laxity. So certain manipulations, especially in the cervical area, is contraindicated for them because of the ligamentous laxity. Not saying that it can never be done, but it should not be done when someone is not proficient in OMM. Rheumatoid arthritis, pregnancy, again, a relative contraindication. There are several techniques that are specific for pregnant women and the issues related to pregnancy, but it should be done by someone who has some sort of comfort with manipulating pregnant women and having the modifications, or understand the modifications necessary for several of the treatments for someone who is pregnant. Strains and sprains, if they're very acute, an acute herniated disc, acute inflammatory situations, anatomic instability, hypermobility, prosthesis. This doesn't necessarily mean like anyone who has a knee replacement can't get OMT. It just means that when you have someone, there's techniques have to be modified because you don't want to be applying pressure for certain techniques into the prosthesis. Often, or if they have limitations, the prosthesis doesn't have full range of motion anymore. You don't want to try to force it or try to work on it with that. And certain visceral disorders, so if there's any like organ failure, probably won't want to manipulate. These are just some red flags to try to like a mnemonic V first. Vascular disease, fracture infection, radiculopathy. This radiculopathy is very relative because a lot of people do get referred to OMT clinic for radiculopathy, but it's more so for spinal cord injury like cauda equina syndrome or saddle anesthesia, things like that. That's what that means. Stroke, recent stroke, spinal stenosis, and trauma. If there's obvious trauma, then OMT is probably not the best. Tumors and thrombus. If they have a DVT, you don't want to manipulate that in case that should become dislodged. Okay. So how would we bill for this? And this is important for anyone who has an outpatient practice. When you're billing for OMT, there's really two things that you have to, or a few things that you have to remember. Now, more often than not, OMT is done on an established patient. Rarely will you get a new patient, so that's why I put the 99212 to 214 in there as the possible E&M codes. You can only bill the E&M code if the OMT was done at the time of the initial presentation of the problem that you did OMT for. For example, person comes in, they haven't had neck pain in a long time, they have neck pain, you're like, oh, we can manipulate this, and you manipulate it, then you've evaluated the problem, you've done an evaluation of the problem, you've managed the problem, and you did a procedure on that problem because OMT is considered to be a procedure. In that case, then you would apply a 25 modifier to your E&M code and apply the proper CPT codes. The CPT codes are basically the 98925 to 98929 are based off of the number of regions you've treated. And they start from 1 to 2 regions, 3 to 4 regions, 5 to 6 regions, 7 to 8 regions, 9 to 10 regions. Rarely are you going to bill for 9 to 10 regions. Okay? Almost never, and especially with you guys, you're probably never going to bill 9 to 10 regions. But some of the templates that are saved in eClinical Works for our residents always have 9 to 10 regions. So please check that. Okay? It is not good to have 9 to 10 regions consistently. Or very rarely would you have that. And if you did, you probably didn't have an E&M code with it because 9 to 10 regions takes a while to do.
Subsequent visits, we would do just as the CPT code?
If subsequent visit means that you scheduled them for OMT. Okay, so like you said, you know what, why don't you schedule an OMT appointment? There's no E&M code associated with that. It is just a procedure code, just like if you had to schedule for an IND or you scheduled for a Nexplanon. There is no E&M because you're not doing an evaluation. You're treating. The important thing to do is have your diagnosis code. So the diagnosis code of what you're treating has to be there. You can't just have 8 somatic dysfunctions on there and send it for billing because that doesn't mean anything. Are they having shoulder pain? Are they having trapezius spasm? Are they having SI dysfunction? SI joint pain? Like you want to mention all of those codes into your E&M into your diagnosis in addition to the somatic dysfunction codes. The somatic dysfunction codes are the M99 codes. So they all start with M99.0X, depending on what region is. 00 is cranial, 01 I think is cervical, and it goes through the list of things. But that should not be the only diagnosis that you have. This is something that's routinely forgotten by residents when they're billing, is that they forget to put shoulder pain or something else there because they're just using the template. And that should be the primary diagnosis. Wherever the pain is, that's the primary diagnosis. Let's see.
So it would be shoulder pain, primary diagnosis, and then an M99 point whatever for somatic dysfunction of the shoulder.
Yes. Yeah. Or upper extremity would be the upper extremity.
It's done by zones. Right?
It's done by zones, yeah. I didn't put all of them in there because the EMRs typically have them in there. Let's see. Is there anything else important I want to say? If you have someone who's scheduled for OMT and they have a other general medical problem, which is not uncommon in our clinic, like out of control blood pressure, and you end up managing that blood pressure, then you would convert it back to an E&M code with a modifier, and your primary diagnosis would be the issue that you addressed. Okay? You're doing two separate visits, although that was scheduled as an OMT visit. Does that make sense?
Mm-hmm.
Okay.
Using the modifier 25.
Yeah. What does it mean by RVUs? So these are the CPT codes for OMT, and they're based off of the number of regions you've treated. The 2-9 is the 9 to 10 regions. But yeah, this is how much work values they are. So if this were a RVU, if the residency was an RVU-based clinic, that's how it would be for you. This is an RVU-based, right? Your RVU, yeah. And this is what the reimbursement would be like for that. Let's see.
Well, and the reason that's important for the residents is because if they're doing this work and they do, it's one of the things I'm trying to tell them in their contract negotiations. If they go in and they do it based on the gross number of encounters they have, then the nurse practitioners and PAs are seeing it learn because they're seeing much lower complexity patients at a much faster rate. So I've encouraged all of them to really try and get credit for their RVU productivity because they should outproduce, but it's based on the complexity of the patients they see. In this case, obviously that can be added to their RVU count, correct?
Yeah.
So it's additive?
Yeah.
What would you say is the most common OMT code that we're using? 2.6, 2.7?
If they're doing it with me, more than likely it's a 2.8. Okay. If they're doing it with you guys, probably a 2.6 or 2.7. Okay? And occasionally a 2.5. 1 to 2 regions is like if they're really just addressing that one particular thing. Okay. More often than not, if they're doing anything, they'll likely hit three regions. Okay? But there also has to be like the interest from the resident, right? They may just do that one thing that you prompted them for, so you may just have a lot of just 1 to 2 regions. So that's the only thing.
I just asked because it's a little harder to get one RVU.
Yeah. Like this is like if you're doing it as a practice.
Mm-hmm.
What are the total number of regions that exist? Is there
10.
only 10 regions?
10 that are billable. So the regions would be your cranial region, cervical, thoracic, lumbar, pelvis, sacrum, upper extremity, lower extremity, ribs, and visceral. So if you're manipulating like the diaphragm, for example, that would be a visceral technique. We don't do a whole lot of visceral. Visceral and cranial are two techniques that are done more, I would say, by the neuromuscular medicine specialists, which are basically the guys have done an extra year or have done a 4-year program in OMM. So they've delved much deeper into the different modalities and their applications than the average resident. Our resident should not have a 10-region billing for any reason. Even 9, I would find it to be very suspect. The important thing to remember, at least for our residents, is, and I've reminded them, is that sometimes they misdiagnose some of their regions that they're working on. So if they find asymmetry, for example, in leg length, they mark it as a lower extremity dysfunction, which it's not usually. Lower extremity dysfunction is typically knees and ankles or fibular head. It's not leg length discrepancy. It would be sacral or pelvis that would be the issue, the reason for why there is a functional short leg. And the treatment that they do will always target the pelvis when they're correcting a short leg, at least the way that I teach it. And it always corrects. That's the caveat. If they're working on shoulders, that's the upper extremity. If they do a suboccipital, that's the cranial region. Okay? There's none of them I know for a fact know how to do cranial manipulation, except for the suboccipital release. Let me think, is there anything else, caveats to this? No, so one of the big things that was omitted was HVLA. The reason HVLA was not included in this presentation was because I don't think that that's a good idea for you guys to be supervising them. No one currently in our residency class has been certified as proficient in OMT. Not that because they don't have the skill set, it's just they haven't gone through the process. If a resident were to tell you that I'm certified, essentially you can just allow them to manipulate as they will, only looking out for contraindications and appropriateness, and seeing if the patient is tolerating it. Sometimes they're just so excited to try something that they don't realize that it's uncomfortable for the patient. So those would be the reasons for a certified resident that you would allow them to do HVLA. High velocity, low amplitude. So it's basically what you would think about chiropractic's cracking. Like if there's a crack involved, it's HVLA. Yeah. It wasn't the focus of this. So we are now going to do the demo part of it, and just kind of going over some of the treatments so that you're able to recognize and kind of appreciate what they are doing, and also be able to do a few simple things. If you find yourself in the situation where you have to sort of instruct on what might be a good technique. If we do take MDs, that probably will be where you'd be like, oh, there's a manipulation that you can do, and you can teach them. Let's go up to the techniques. Okay, so if you guys want to pair up and get to a table each, I guess you're over here. You're already at the table, so.
And I'll volunteer to be he's worked on me before, so I'll volunteer to be his model to show you guys.
All right, I do ask that you take your shoes off because I don't want the tables to be scuffed up.
Yeah, we just got these tables, right?
Well, yeah. No, they're the residencies.
Keep them pretty as long as you
I'm gonna assume it means a belt with a buckle.
Am I in the frame?
I'm gonna just
It's okay. Yeah, we're going to be working on this table, and I'm just going to be around this table. We don't really need the screen in there.
You're dead center on that table.
Okay, great. It's helpful if you had pillows because some people just can't tolerate lying flat. We, of course, don't have pillows to use. For the guys, just loosen your belt buckle because some of the leg techniques it's going to be very problematic.
I just took my belt off so it wouldn't scrape the
Yeah,
leather.
yeah,
Bill, if you don't mind taking your belt off.
yeah. It will be a lot easier for them to do some of the techniques on you. Does anyone need a break by I should ask. Does anyone need a break or
Yeah,
bathroom?
plenty of places that would be suitable for some of these things.
Okay.
Pop break in the beginning.
All right. So whoever is the table model first can go ahead and lie down on your back.
Wanna be the model? I figure we'll switch eventually. right? Okay.
I can't wait to do this to shake. That'll be fun.
All right. Okay. So the first thing we're gonna do is one of the I think the first technique I ever learned is the OA release. The suboccipital release is the other common term for it. So let me just go back to okay. So here, this green area, and is where you're trying to put your fingertips. Okay. So you're gonna just lift the head up and
Not you.
yeah, lift their head up. I should.
Passive.
Yeah, this is a passive technique. There should be no involvement from the patient. So go ahead and just you're gonna find that occipital ridge there. Just below that is where the muscle groups are and where the suboccipital trigger points are. Sometimes if you feel like you can't really feel it, you can just apply some pressure and say, is that tender? You should, in most cases, feel an asymmetry there. There should be one muscle that is more posterior. It almost feels like they're uneven. And that's because there's a dysfunction there. Yeah.
Maybe this one's a little bit more.
Shoulders.
Barely this one.
Yeah.
Just a little bit more. So how much do you lift or just?
So you're not necessarily lifting. My hands are resting on the table underneath with just my fingers tilted up. Now so there's chairs. That's why I brought these chairs so you guys can be a little bit comfortable when you do them.
Oh, I'm sorry, I moved that chair. I'm sorry.
No, that's okay. Yeah, and yeah, so you can keep your forearms on the table so that way this should not be something that you're applying yourself for. There's not muscles really involved, yeah. The only thing you're doing is just this. It should just, and basically sometimes the patient will try to hold their head up because they think it's heavy, and you should just relax into my hands or as if it were a pillow. You just tell them that, and they tend to understand that. And let your head rest on my fingertips is another thing that I say, and then they usually get that. So you're going to hold, and I'm going to check all of you guys. You hold this for about 30 seconds or until you see you feel a muscle release. So if you remove your hands, I'm going to do it, and then you just follow my fingers. Okay, relax your head. Okay. Follow my fingertips. Okay. Do you feel that? Do you feel that?
Yeah.
You're holding your head. Relax your head and
Yeah. And a lot of times it will feel good. So that's you're gonna feel bony, a little soft spot.
Okay.
Okay.
I was a little too low, I think. Is that okay?
Okay. All right. Go ahead and.
You want to come over here and do it again?
Okay. Go ahead and find just where my middle fingertips are. Okay. Do you feel that the soft areas you can feel that it's muscle just and all around is bony?
I think I was down there, so I think it was about a half centimeter.
Yeah, yeah, and oftentimes it's just you're just a hair off, and when you
Better?
even though you were a little bit off, the effects usually works.
I was gonna say, I still felt his muscles
Yeah,
relax.
it usually works. It usually works. Okay, so I think everyone's had it. We'll just hold it for 10. Okay, go ahead and switch. Yeah, go ahead and switch.
Just say roll off. Yeah, so like
I knocked the little thingy out
That's okay.
on the ground.
That's okay.
we're always practicing on the same beat.
So when you're working your way down to this, you just like to start this part of the head.
Yeah. So just go a little bit higher. So find the bony ridge
So you like it on the bony ridge or just below it?
just below the bony ridge. Yeah. So you're actually pushing up, right? You don't want to push up. You just kind of want to have them like this is what you want. You want them to have rest. You want it to be so comfortable that they don't mind closing their eyes.
Gotcha.
Okay. If they're doing this, that means something's wrong.
So is
Okay.
that about right there?
Yeah.
Just enough to.
Yeah. 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 Okay. All right. So let's go ahead and feel. You sure you don't want to sit down?
No, I'm fine.
Okay. All right. Let me
Yeah, go ahead.
get under there. Okay. All right. Go ahead and follow my fingers underneath and where my fingertips are, middle finger. Okay. Do you feel the?
Does it feel like a different spot or the same spot?
It's pretty close, actually.
Yeah. So where that muscle is, you'll find that on her left side, it feels a little bit more like tense than the right side does. So if you feel a difference, then you're in the right spot. All right, Bill, let me get under there.
How about right there?
All right, I'm gonna go under there, and then you follow my fingers there, okay? All right, okay, go ahead and where my middle fingertips are. A little bit lower,
Closer together from where you first positioned your hands.
like there, okay? Go ahead. Yeah. And just kind of let her, move your hands a little bit more like this so that you're kind of cradling the head a little bit.
When you were showing exam earlier, at least in diagram, it showed the thumbs looking for asymmetry in the neck.
Yeah.
So before we actually do the technique, when you're actually looking for asymmetry, are you doing the thumb exam up the scalenes and up to the inner
So
line on both sides, or-
So oftentimes I do the exam as I'm treating, like as I'm going through it, I exam.
Yeah.
I do an exam as I'm going. So if I find a dysfunction, I treat that dysfunction. This, in academic OMM, you're doing a structural exam first, identifying all the lesions, diagnosing them, then going ahead and treating those things that you found. But no one has time for that.
That was manipulated all my life.
Psychologically or physically?
That's probably it. I got that high.
All right,
frequency.
good?
They would,
Huh?
put you in a
Yeah.
position and they crack it, they give it a quick jerk.
Who did that?
Well, my grandfather's a chiropractor.
Oh, yeah, chiropractor.
Well, that was the high velocity,
Yeah,
low
that-
amplitude.
yeah. HVLA.
They're definitely into the high velocity,
Yeah.
low amplitude stuff.
Yeah, and
They taught us several techniques that I used to use on my father used to use it on my mother and
Yeah.
vice versa.
do you know any still?
I'm trying to remember, there's one where we put our arms around it,
Yeah.
and then I would grab them around here and
Yeah,
lift them up.
yeah. So that's
My belly would go into them and would crack their low back, because I would lift them off the ground like this.
yeah.
I remember that one.
That sounds painful.
Of course, there's the one putting the neck to the side going like that, till it went crack.
Yeah.
Twisting the neck to
So-
the side and then giving it
So a lot of times people don't enjoy that. Okay, so let's get.
Process with afterwards. If it's
And then they put one leg over the other one.
Okay.
And then, push the leg up and the back.
Yeah. All right, so let's now do the soft tissue / myofascial. Okay. Now, soft tissue is usually just in one plane versus myofascial, which is in 3 planes. It's semantics, but it doesn't really make a difference. Okay. So go ahead and lie on your stomach now. Okay. So Yeah, you can turn your head whatever way is comfortable. It doesn't really matter. Sometimes people even like do one of these things. Okay, so for this one, you will engage the myofascial structures underneath. So the way that I tell residents is how you know you're applying enough pressure or versus too much pressure is that if the tips of your nail beds or fingernails start to turn white, that's usually enough pressure in the average person to have engaged the myofascia. If you don't have any pressure, you're probably just engaging skin/adipose tissue. So there's a little bit of pressure involved, and you check the motion of the myofascia underneath. So for him, we're gonna do this as a direct technique. So direct again means going into the restrictive barrier. I'm finding where the restrictions are. So going superior is the restriction. I'm gonna keep that, hold it there. Then I'll engage the second plane. So he's more restricted going to the right. So now I'm going to hold it there. So I have a superior and a right right now. Then I'm going to add counterclockwise or clockwise, and he was restricted to clockwise. So now I have him engaged in 3 separate planes, all into the restrictive barrier. And I'm going to hold this until I feel those muscles start to relax underneath. When you're doing any of these techniques, you can have the patient take deep breaths, and it helps the muscles to relax because the patient themselves is forced to relax. So go ahead and take a deep breath in and out. And that's called a respiratory assistant in the osteopathic world. And then you check it again, and you should have better motion in all 3 planes. Okay? So go ahead and try that. Whenever you're doing manipulation or whenever you're documenting manipulation, whenever you're doing documentation for manipulation, you have to remember that you specify what modality you used and what the effect was. So if you have, for example, a thoracic dysfunction, you have to say treated with myofascial release, and you have to see what the effect was. So improved, resolved, not improved, worsened, because the CMS will not pay for manipulations that don't have a reassessment associated with it.
And you're using your fingertips, your palms, fingertips?
Either or, whatever you feel, whatever is comfortable for you. Okay?
Is the patient going to feel any soreness when you get to the
Restrictive barrier?
right area?
So if you're doing it over a tender area, then yes. But if you're not doing it in a tender area, then no.
Don't worry about hurting me, Bill.
Yeah. So you want to apply a little bit more pressure. So, okay, see now how my fingertips just turned white from the top? That's how much pressure you want.
Going to the barrier.
Okay?
So I'm pushing left
Yeah.
and rotating down like an up with my right hand.
Okay.
Yeah.
Yeah. So basically,
She was more tight on the left.
yeah. So it's really this much pressure. See how it's just barely. Applying this much pressure, it's usually uncomfortable, and they start to tense up, so you're defeating the purpose. Okay.
So it's not a massage, it's a...
Yeah, it's not a massage. Massage therapists tend to utilize this technique to get stubborn areas, but also you're going to massage for like an enjoyment thing, right? You're not necessarily going always for.
In this case, it's direct or indirect, so we were doing direct case.
Yes.
Going to the area of the most resistance, correct?
Yeah.
So in this particular case, just one pressure. Okay, definitely more pressure going down
Yeah.
than up. And so,
Tension on the second time.
more going over to this side, so down to the left. So down counterclockwise and left is what I'm trying to do. Deep breath. Go up. And there's what it goes.
Yeah, perfect.
I can feel it.
Yeah, you should feel the relief. You should feel the release.
And you're trying to get that myofascial plane involved, so really what you're feeling is the muscles underneath
Yes.
the tooth, and you're feeling them.
Exactly. So if you've only engaged the skin, you're basically going to be holding it all day because you haven't engaged the muscle underneath.
Right.
I can't tell your fingertips.
I know.
I have to trust you.
I was looking at this part.
That's
of my
fine.
finger.
If you're leaving claw
So,
marks,
yes.
you probably.
I know.
That's fine. So yeah, I tend to grab a lot of surface area, but it's up to you on how you want to do it. If you want to do small sections at a time, that's fine. No. So a lot of times for some of the manipulation, you'll notice that I'm on the table with them, and for certain techniques, that's kind of necessary. When you are doing the when the resident is doing the exam, this needs to be in the physical exam section of the clinical works. There is a separate OMT section in clinical works that's just slightly below the general physical exam, and this is where you're going to have to make sure that they've documented appropriately.
Yeah, she's gonna get a hold of you, Bill. See how you do,
Okay.
brother?
So when you are reviewing their notes, the very important thing about any of these dysfunctions, though you can turn your head to the side if it's easier. Yeah. The important thing to make sure that you have in your documentation is lateralization. Okay? It's just like any other physical exam. You can't say if you're assessing for range of motion issues for like a shoulder problem, right shoulder. You can't say that. You have to say restriction of motion or restriction somewhere. So like if we're doing the OA, for example, and I tell you like, the sides feel different, whatever side feels more tight, I write OA right restriction. That's it. That's all you have to write.
Because,
Where did you
and,
say-
go ahead.
Bob, where did you say you find that part in ECW?
ACW, it's in one of did they create that template or?
Yeah, so it's not gonna be in Texoma Cares, but we could print out the template that they have created and you could just create your own template.
Okay, that would be good.
Yeah,
'Cause otherwise I won't remember, I don't think.
yeah.
But I noticed
You
the
could-
terms that you're using are form and function terms rather than spasm or anatomy.
So I
terms.
do use spasm a lot of times. So like I can use spasm in there, depends on the context, right? So
If it's somatic, what are we gonna be using now?
if it's somatic dysfunction, so if it's somatic dysfunction, remember the way that you describe the a dysfunction is tart, tenderness, asymmetry, restriction of motion, or tissue texture changes. So tissue texture changes is tightness, for example, or ropey, or some type of descriptor of that particular thing. But you have to lateralize. A lot of times the residents will say OA restricted. This is like saying arm hurts. You need to lateralize it. If it's not lateralized, it's not valid for a physical exam finding.
Tart.
Makes more sense why I was doing some of the other things that our residents describe things as ropey, and I was like, that's odd.
Yes. Yeah.
They're talking about other things, you know what I mean, when
Yeah.
we're not OMT, and I'm like,
Yeah.
okay, I guess.
What'd you say TART stood for again?
TART stands for tissue texture, asymmetry, restriction of motion, and tenderness. Tenderness is, so if some spot hurts, like if the thoracic hurts, you can write tenderness T2 to T3 or T5. There's tenderness there. That is a somatic dysfunction.
I've always been good at finding tenderness, sir.
Yeah.
It's the other stuff I need to work on. Okay.
Okay, so we went over OA, soft tissue, muscle energy, and the muscle energy we're just gonna like I'm giving you like examples of some of these. Like the soft tissue was an example on the thoracic. You can do that on the lumbar. You can do that technically on the arm. But let's go ahead and do muscle energy, and we'll do rib raising. So go ahead, partner one, lie on your back. And we'll do this one for low, like with someone lumbar. So someone was coming in with low back pain.
Oh, good. Okay. Yeah.
Yeah. So with low back pain, lumbar. So you're going to go ahead and palpate. So usually you're going to be checking. So find the spinous processes and just go lateral to them, so you have the paravertebral muscles there of the lumbar, and just check to see if anything feels asymmetrical, or which is not necessarily asymmetry, it's the tissue texture change, because one side feels tighter than the other side. Okay, so you find the side. Okay, it's this side, so I'm going to treat that side. If you're doing OMT, I always tell the residents, finding the lateralization is good, but you're going to want to treat both sides, because what will happen is that both sides have dysfunction, but because one was significantly worse than the other, you treat the good one, and then you realize that the other side had one. It was just a little less noticeable. So bilateral treatments is like my rule of thumb. If you're going to do a treatment one way, you should do it the other way. All right. So with muscle energy, what you're going to be doing is you're going to be engaging the restrictive barrier. Okay. So for this particular manipulation, it's the lumbar. One hand you have to kind of monitor underneath on the lumbar, so you know like when you're moving the leg around, which muscle groups are engaged. Okay, so a lot of our residents use this muscle energy for the lumbars. They bring the leg up high. The higher you bring the leg up, the higher the muscle group is engaged. So you could, in a nimble person, get up to the thoracolumbar, low like T12, T11 areas if they're able to flex that high. A lot of times you won't be able to because they have dysfunction there. So basically, you bring it up to until you feel resistance. That's the restrictive barrier. Once you start catching something, in our schools they used to call this the feather's edge. It's just when you hit that change in the ease of motion. So bring it up there, and then you have them reverse the motion. So if he's doing a flexion, you want them to go ahead and do an extension, reciprocal inhibition. The opposite. So why don't you take your leg and bring it down towards the table, and I usually tell them like follow it like this.
Okay.
Okay, go ahead. And more often than not, okay, relax, they're going to use a lot more strength than they need to. They only need about 5 to 10 pounds of pressure, enough that you feel the muscles under where you're palpating tighten up a little bit, because that's what you're trying to work on. So go ahead and push.
So you're inhibiting him pushing, you're holding it. Okay.
Yeah. And go ahead and relax, and then I'm going to accentuate that to the next where I feel it again starting to catch. Go ahead again and relax. So I'm having him exert for about 3 to 5 seconds and then relax. And sometimes you need to fine tune it. So if you feel like, okay, I'm not really getting the muscle, so you just kind of have to adjust it a little bit. By coming out to in an abduction, you engage the medial aspect of the paravertebrals. If you go into adduction, you engage the lateral aspect of the paravertebrals. So for a lot of people, like I'm a smaller person, I sometimes have to bring my leg up to the table. That's totally okay. Some people are very, very tall, so I have to make adjustments for myself. Sometimes I'll put my hand here to kind of use that. For women, sometimes using both hands, so they have to just palpate it where they want and put both hands here. Sometimes they'll put a pillow here and then use that to kind of create a barrier between the patients. So go ahead and try that. Did that make sense?
Kind of like a ratchet.
Yeah, yep, yep. So you're going to palpate for some dysfunction, and then you're going to bring the
And if you
leg
find
up.
anybody dysfunctional, let me know. They're not under no stress, probably. Not dysfunctional.
Yes or no?
What? Yeah, that was tender.
Yeah. Was not as difficult. Okay, so.
And remember not to help her.
Let's see.
You're helping her.
Just now, so can we relax?
Which one do you feel worse?
I know it is really difficult.
Well, he does hot yoga, so,
He told me.
yeah.
Yeah, so
It's not bad at all.
he'll probably won't have any issues, Dr. Mabry.
Doing his hot yoga.
Yeah.
All right, ready?
Oh.
You ready?
Yes, ma'am.
So we're just going for the paraspinous, which in your case is your left side. This side feels much
Yeah.
more tense to me.
Yeah. And when you're palpating, you don't necessarily have to push too hard. Once you do this enough, that's very light pressure is necessary.
Yeah, I'm probably hurting you, brother. I'm sorry.
That's
That's
okay.
what my children always say. My wife, that I push too hard.
Yeah. So you're literally like a light touch is ideal in this, so that you can feel the minute differences in the tissue texture changes.
Okay. And so in this one, basically what I'm feeling for then is lightly. Feeling here for the,
So basically you're going to adjust the leg until you feel the muscle group that you're trying to work on engage,
okay, gotcha.
right?
Yeah, we're coming back.
And it's engaged.
Yeah. So now when you
Okay.
when you bring now that muscle group should feel like it tightened up a
Oh, it
little bit.
did.
Yeah. And then I'll hold it for 3 to 5 seconds, and then I'll relax, and then you're going to accentuate that
Right
barrier,
there.
and then go ahead.
Relax it.
And we got lots of back pain, we see it in our,
Right in there. Yeah.
walking around 50, 60 pounds of it.
Relax.
Yeah. Perfect.
Okay. You got tight back muscles?
Relax.
Yeah, you did good work on this side.
Yeah.
Ah.
Okay.
Does that make sense?
It's a lot of pressure, yeah, and you
No.
can really kind of feel and.
Yeah. So the lighter the touch, the better, because you want to detect subtle changes. Sometimes the muscles, if you push hard enough, then the difference is gone. Like you won't be able to
I tried
appreciate
too
the
hard,
difference.
I'm pretty sure, and
Yeah.
I got lighter.
And also, it's uncomfortable if it's tender.
Yeah, I can push hard enough, it actually makes them get tense.
Yeah. It's like it's not. It wasn't tender before, but it definitely is now.
I induced it.
All right. Let's get the leg almost straight up here, so it's harder to push it.
All right, Bill, you ready to get your back done?
Sure.
Yeah, she's on it.
You want to get the crack on
This is actually very enjoyable.
No.
It's good because there's a lot of terms that you're teaching us and things that are so basic to an osteopath. But these were courses that you got in first and second year that basically just never got those courses.
No, you're right.
You know, so the terms, the terminology and how you are doing these things are just not.
Yeah,
things that-
it's
that
not
we
intuitive.
use.
Like, yeah.
Well, the thinking process will be different. Like I
Yeah.
said, I think the form and function approach to things rather than just a strict anatomical, pathologic approach is much different, you know?
Yeah. Yeah. So the goal is to basically demystify OMT
Absolutely.
and just make y'all realize that it's not a
Well, just knowing that they're actually putting the right thing in their note,
yeah.
that they're building it correctly, and that they're doing it in general in a correct fashion.
Yeah.
Right.
Just the goal for this is like basically you prevent harm, right? So prevent patient harm, which is our goal, and
You know what your first challenge is going to be? There's a lot of this that goes on in our clinic It is never billed, never documented, and never told us about it, and we're never told about it. Because they, quote, don't have you there to supervise whatever, so they just do it, but they don't document it.
Yeah.
So our biggest first challenge is gonna be to get them used to saying it, because some of them are not gonna want us to come in and watch them do it.
Yeah.
Because we're kind of doing it on the fly.
Yeah. So for CMS, this is counts as a procedure for. So CMS says that they need to be supervised for a significant portion of the procedure. So if you did if they did one technique in front of you, it's significant enough, and no one has really come back and said which specific manipulations did you do in front of them. Basically, if they're asking to do OMT, they're probably comfortable doing it. So that's the good thing, is that they're probably comfortable doing OMT. As long as you tell them, like, yeah, I'll supervise as long as you're not doing HVLA, and they say fine, you should feel confident that they know what they're doing. I highly doubt they're going to say, let me do OMT and not know what they're doing. Okay? So that's muscle energy, and basically this concept can be applied broadly, right? So tennis elbow is another time that they tend to do this, and it's like if you go ahead and shake your hand, like it's one of these things. So you'll see them like do a handshake thing, and you basically rotate until you feel restriction, and then go ahead and reverse and relax and just keep doing that, right? And that's something that can be taught to the patient as well to do on their own. So if they turn and their hand is like this, there's an obvious dysfunction, and you can usually correct those. I think my computer died, so I'm going to go back to, all right, so,
Okay, is the battery dead?
yeah, I think so.
usually do, I ask them if I have a patient that I think has a suitable problem, I will ask the resident, how comfortable are you
Yeah,
with OMM? And if they're like, oh yes, I would love to do this,
yeah.
then we do it. And if they're like, yeah, I don't know.
Yeah.
then I
So-
don't.
so
And we're
even-
sending them physical therapy.
So even if you have that, like as I mentioned before, we need to be prompting them for like
Patients that may be appropriate.
patients that may be appropriate, not necessarily for them to do the treatment then and there, but for them to recognize which patients are appropriate for OMM and refer them appropriately. So if they say, you know what, why don't you schedule you can have them schedule an appointment for OMT. It's no problem. Our goal is eventually to have dedicated OMT clinics where all of these patients would be funneled into, so that they can get OMT done by people who are in the osteopathic tract once we have one. Okay, so that's the.
It's very well received. You know?
Yeah.
I mean, all my patients are, they're under 21, and most of them are like younger than that. But very much. And I
Yeah.
even had one who, I said, well, I mean, I can send you to physical therapy, whatever. And I think it was Nielsen.
Yeah.
He goes, no, I think I'll just go over there and get Dr. Nielsen. I'm like, that works for me.
Yeah.
So, I mean, some of them are really good.
Yes, and that's ideal. Okay, so we went over muscle energy. I think rib raising is fairly self-explanatory. You can do it in a seated position even. This would be good for like patients who are like asthmatics or someone who has breathing, other sort of breathing difficulty, if they have like a upper respiratory, because this is supposed to stimulate the autonomic system. So as you saw in that picture before my computer died, he basically has his fingers on the posterior rib angles. So why don't you go turn around on that side so that your back is facing them.
Yep.
And if you're doing it in the seated position, you basically are finding their spinous processes and just applying pressure, compression, and outward stretch. Okay, you can do it like this. If they're doing OMT, more than likely they're going to be on their back already, so we wouldn't seat them up for it. So go ahead and lie down. And if you were doing it like this, basically take your fingers, and just like we did the suboccipital release where you're not applying any force, you're just have your fingertips up. That's basically you're letting their own body weight kind of be there. But the only thing you're doing is lean back a little bit to give it a little bit of traction. So
you're doing one side at a time.
so you would have to do it one side at a time. If you had a resident with you, it's typically we just do it together because and patients really like that because it's I don't know, but every time it's like, wow, that feels good. Okay, go ahead and rest your shoulder. So if they have their shoulder up, they've engaged those muscles, and again, this is one of those techniques that you want to have as much relaxation as possible. So if you don't have a chair, which I don't right now, but basically you're on the paravertebrals. I have my fingers bent up like this, and I'm just going to lean back. So I'm not using strength. I'm not using my upper body strength. I'm just leaning back. A lot of OMM is just modifying your posture to and using it as a lever.
How long do you hold it?
You hold it, so some people like to hold it until they feel a release and then move down. Other people will like to do kind of a pulsing, and that's a little bit of what we call articulatory technique, where it's like a gentle pulsing and go down a few times and come back up a few times. But it's up to you how you want to do it. Okay?
I was just kind of thinking, how long in general do you give one side? Like a couple of minutes or a minute? Or
Yeah, like 30, like a minute.
Yeah.
Like a minute. If you're doing it by yourself, like a minute. But yeah, so that's rib raising. Do you guys want to practice that, or do you think you got it?
I think.
Yeah.
Fairly straightforward.
Yeah, okay, good. All right, so there's that. The other techniques for thoracic, so when you have thoracic, cervical, or shoulder pains, then usually the trapezius is involved, and the trapezius is spasm. So when you're palpating, like people say, oh, that feels spasm. Here's some flexural. Well, instead, what you can do is you can engage the scapula itself and treat the trapezius. So how you would do that is in this position, and it can be done seated up as well. You just basically grab the medial border of the scapula. How you would do that is if you take it, if you're having trouble finding it, just move the arm around and you'll feel the scapula move underneath. So I find it. You take it with my fingertips, so I feel this medial border right there, and then I'm basically just doing a rocking motion on that. Rocking motion, and then I'm also have a traction. So I have a traction at the whole time, but at the border itself, my finger is doing a little bit of this. So the traction remains. So it is technically a myofascial technique, where you're engaging and you're using a force vector, and then this pulsating is what they call articulatory technique, which I didn't really feel like it was necessary to think, because all you're doing is just a rhythmic pulsing. Okay, so that would be a scapular release. Okay.
Do you ever repeat those maneuvers in the same office session?
Like doing the scapular release twice?
Yeah.
Not really. Not really. I'm just going to see if there's any techniques that we did not really do.
Steps with you there, Dr. Major.
Oh, okay. So let me do one counter strain technique. Okay. So counter strain. This was the fold and hold technique. Okay. That's all you have to remember about it. It is fold and hold, and don't let the patient move on their own. Okay. So it is one of the this is the tender point. So finding a tender point, and this is where you palpate, and they'll be like, any of these tender.
I mean, you want the most tender or any tender? That's
So it's technically, if there's like a generalized area of tenderness, find the area that has the most tenderness.
Last time I did this, you put needles in my ears.
Yeah. So
And when you're going superior, right there.
Okay, so this kind of it allows for some freestyling in the sense that you're going to be basically trying to shorten the muscle group that's underneath your finger. Once you find that point, you want to keep that point there so that you can assess at the end of it to see if you've actually made a difference or not. Because then people will gonna, like, once you do it, people think, I don't know if that's the same point. Well, it is, because you never moved your finger in the first place. Okay? So what I mean by fold and hold is that by bringing his shoulder out into extension, I'm basically I'm folding in around that posterior point. So after, relax your arm, let me move it. Okay, any change?
A little bit.
Okay.
20%.
How about now?
About 15%, not quite as much as the first time.
Okay, so if you have, if folding and holding is not working, so you notice that there's not much of a dramatic, then you go in the opposite direction. Okay, how's that?
About a 50%.
Okay, so the goal, how about now?
55, 60.
Okay, so the goal is to get it to about 70%. Once you have it at 70%, okay, how about now?
Yeah, you're about 70.
So you're going to just hold it 90 seconds. And
Which is longer than what most doctors do anyway.
yeah,
Honestly.
and this is like where you kind of like do your education. Like, all right, so you know when you go home, this is the kind of things that you want to do. Like if this happens again, blah blah blah. Like this is where you do it. Okay. Some people will add compression into that point to shorten the amount of time it takes to relax it. Now,
Wrinkling his forehead, I'm not sure what that means.
Outside of that point, there's some stuff in the shoulder joint itself, at the acromion.
okay, so once that 90 seconds passed, okay, just relax your arm.
Okay.
You're going to return it to neutral, okay? Like you as the physician is going to return it to neutral. And then you're going to reassess, okay, to see if the point has improved. So that's counter strain. This, you want to try this one? Or are you guys good with it?
Now let's try it.
Okay.
Yeah, counter strain's that's the one that you had Sarah do with me before. She did pretty good for the lumbar spine.
Oh, yeah. Yeah.
Counter strain.
Yeah. So basically, again, we're not trying to learn techniques. We're trying to identify which techniques are being used and if they're being used appropriately. So if the patient, if the resident says I'm doing counter strain, you always want them to identify what modality they're using.
It was a good learning experience for me actually to be a patient of the resident. You know what I'm saying?
Yeah, yeah.
Okay.
So now we're gonna do, let me just move your arm back,
Your right hand.
okay?
Mhm.
Better?
Yes, it feels better. About 30%.
Don't move it, let me move it. I feel like you're helping me.
Oh, yes.
Try really hard.
I thought maybe it'd be the best relaxer in the new.
Okay, so then we just hold it, okay.
He's a T-Rex. T-Rexes have a hard time relaxing.
Same, worse.
I can feel it changing.
It's an eating day. I'm thinking about that steak I'm gonna have.
Think of this as a blood pressure. Relax
Yeah,
your arm.
yeah. So 90 seconds or until you feel it relax.
It's like a little ratchet letting go.
It did feel a little relaxed, yeah.
Hold your arm. About that. Right.
Yeah.
Interesting.
It did really-
Okay.
Cool.
Now you gotta pick on her.
Now,
I bet you've got all kind of tight muscles and that. This would be a good couples class, sir. We need to do couple
I was just thinking,
osteo.
I should have had my husband come.
there you go. Yeah, that would-
Oh my gosh, he'll have to watch the video.
Yes, absolutely. Don't think I won't be trying this on my wife now. I definitely do that.
Yeah, kind of feeling a little something here, is that feel?
I agree.
Pretty even so far.
Well, I think because you're about to hit the
So
egg
you're
talked about earlier. On the right
Try
side.
to take the strain off.
And sometimes it's just easier to say, hey, why don't you point to the spot that hurts the most? And that usually speeds up finding it.
It's like if you go lateral just a little bit.
Yeah,
Right there.
yeah, yeah.
That's where my wife always gets hers too. The superior medial border, right over where that rhomboid in the trap is coming down, that center head of the trap, rhomboid, and then the paraspinous. Because you got 3 layers and you've got a ganglion there, so.
Yeah. So remember, when you're monitoring, you don't want to continuously apply pressure to the point. Okay? That's really just a monitoring finger, just to remember where to check.
So now I gotta reassess. Now, does it feel better than when I first palpated or not?
I would say yes.
Sounds good.
Yeah, I only think you gave her 52 seconds though. That's what happened. You cheated her out of 48 seconds.
Oh, my.
Oh,
That's
no,
what happened.
worse.
Sometimes, so the other thing is sometimes just the therapeutic touch is all that it is something that helps as well, right? So some patients just want you to touch them, and OMM offers that because it's been removed in most examinations.
And it may be hogwash up. Sometimes I'll do a little acupressure, if you will. Not puncture, but I will put pressure
Yeah.
on some of those points and just hold it for
Yeah.
a bit until she relaxes.
If you do it counter strain, it will relax faster and it will be more long lasting, because now basically the idea behind it is that the muscle itself is forced to relax by being in a configuration that doesn't allow it to be spastic.
Gotcha. Which is different, because most of the time what we're taught is to stretch it. So basically, if it's spastic, you find yourself doing the counter of spasm, which is to extend it or stretch it.
So in a spasm, essentially the muscle is stuck in a particular configuration, right? So if you exaggerate a different motion for long enough, it has to let go of what it's been configured as, where it's stuck as. So that's why counter strain is used. So counter strain is essentially when everything else is not working and it still hurts, I do counter strain. The reason it's one of my last resorts is the amount of time it takes for me to actually do the technique. The 90 seconds is it's a long time, especially if you have multiple regions that you want to do or there's multiple tender points. So for me, it's a cleanup method. But for some, it's the primary method, and that's okay. Okay?
In general, how much time should it take, if done with proper technique, for each, I guess, zone or system? So we talked about them being in 2s. So if somebody is doing, let's say, 4.
Yeah. So for 4, depending, again, it's like if they have a system, right? I have a system that it is my flow. I have a flow that I do, regardless of what you came in for, you're going to go through the protocol that I have. And that takes me about 20 to 25 minutes if there's not any major hiccups, right? For the average person who actually needs OMM. For a young person, I can get done in 15 minutes. But you have to modify a lot of these things due to limitations. Usually someone who's coming in for OMT has a limitation of some sort. They can't lie flat. They have to keep their legs bent. They can't lie on their stomach. There's something that would disrupt your normal flow. So when we do it on each other, this is not a real example of an OMT, so it shouldn't be used for like gauging time-wise.
Well, that's what I was asking. So if a resident is going to do this,
I usually have them half-an-hour appointments to allow for those issues and to allow that I'm actually going to be involved in teaching them something. That's not always the case. All right, so that's kind of the major modalities and how to utilize them, the contraindications, the indications for manipulation. I hope that you guys were able to feel more comfortable supervising. Is there anyone that still feels uncomfortable like supervising at least this set of modalities? We did not, no one should be precepting HVLA. The reason is because because there are complications that happen, and if the technique is not perfect, that patient will hurt afterwards. Okay, so no one should be doing HVLA. Yes, just as a blanket rule, no one should be doing a cheerleader. Okay. Anything? Does anyone have any questions about anything?
I think the main thing was just, at some point, maybe watching you go through, or if we have another session, just going through, okay, when you walk in, this is how you do the top to bottom evaluation. This is how I'd specify on this. This is how I pick about how many I would do. And the reason I'm saying this is because what I try to teach a resident, certainly with the allopathic part, is flow, just like you said. So the one thing I don't know necessarily is does the flow of an osteopathic go, and then specifically how can they work in small aspects of this into regular clinical visits. So if there's just a one or two type of thing, because I know some of them say they'll get somebody that maybe they'll just do OA.
Yeah.
On a patient who's got, well, let's just say they got cell phone neck.
Yeah.
And that's what I call it for the young people anymore. They basically end up with the cervicalgia secondary to their mobile devices.
Text connect. Yeah.
And so the OA technique and some of those things, but that would be my only other thing, is just trying to see how would that be incorporated, what I should expect the resident to be able to do.